So let's move on and focus now on Ponatinib, and where does it have a role in the treatment of relapsed refractory CML?
Well, Ponatinib is very effective. I mean, the response rates in the third line, well, actually it was third or beyond line of therapy, that PACE study, 60% of patients had received at least 2 TKIs, 90% had received at least 3 TKIs, and yet the rate of major cytogenetic response in the chronic phase was over 65% on these patient populations, so incredibly effective. If you put that in the context, and most of these were actually complete cytogenetic responses, so about 55% of these responses were complete cytogenetic responses. If you put it in the context of, for example, the second generation, dasatinib, nilotinib, or bosutinib after imatinib failure only, those studies showed a complete cytogenetic response only 40%, which we value, but it tells you how Ponatinib was incredibly effective. So definitely a patient that has had at least two prior TKIs, Ponatinib is very effective in that setting, and of the drugs that we have available, I think it's the most effective. Not to mention, of course, the T359. That's the only drug that works. So that no matter how many prior lines of therapy, if I have T359, Ponatinib is the way to go.
It was interesting in the results of the PACE study that you published. The response rate in the T315I population seemed to be a little bit higher than just in the relapse refractory setting.
That is correct. That was the group that had the highest response rate. Some of that had to do with the fact that they had received fewer prior therapies, because once they developed that, there was nothing else to give them. But it also reflects the high sensitivity of the high efficacy of Ponatinib against the T359.
And recently, you've given us an update from the PACE, a 5-year update. Are patients being able to stay on Ponatinib and stay in response?
Yeah, absolutely, and that's very important. These responses are durable. It's not just a transient response and they come up with something else. These patients have been, the patients who achieved a major cytogenetic response, that was the primary endpoint, but then we have many patients, a high percentage of, it's almost 50% of patients with major molecular response. They've also been able to maintain their major molecular response. So certainly the patients can maintain their responses for long term. These results that you're talking about, it's a 5-year follow-up, so they are durable responses.
Okay. So you've had a lot of experience with Ponatinib. We've been made to be quite concerned about the toxicity of Ponatinib. What's your experience been like?
Well, that's where we started recognizing the risk of arteriocclusive events, and certainly we probably didn't miss it. We didn't recognize it early enough. Only as the PACE was starting to finish enrollment and the data started coming up, we realized that there was a significant number of patients who developed these events, either cardiovascular, cerebrovascular, or peripheral arterial. And there's no question that it has risks. Now, I believe that some of that, a good part of that is the drug, and we can talk about the mechanisms why that happens. But some of that was that, and that's a lesson for any of these other drugs, is that we were not paying as much attention as we should have to managing their diabetes and their cholesterol and their hypertension. I mean, if you look at the curves of the blood pressure during the management of these patients on Ponatinib, blood pressures were way high, and they remain high, which means that we were evidently not doing a good job at controlling the blood pressure. I don't think we would have eliminated the risk by controlling better these risks, but I think that we would have decreased the risk of developing these events in at least some patients if we have done a better job. So that's a lesson to learn now, that to say, sure, these drugs, and Ponatinib in particular, confer a risk. But that makes it more important that the patient is not just the PCR. You need to monitor everything else and manage that well. And with that, I think that we can use Ponatinib more. For a while, there was big scare, and people were not using Ponatinib at all. No, I think it's a good drug. We should use it when it's indicated, but we need to use it properly.